Hello, and welcome to a study guide for the Fisdap Trauma Exam. This presentation is going to cover a range of trauma scenarios, focusing on specific injury types and appropriate assessment and treatment techniques. The topics are organized into the following categories. So abdominal trauma, we're going to identify and manage injuries to the abdomen. Assessment techniques, and these are going to be key considerations and best practices in evaluating and managing trauma-specific patients. Then we'll talk a little bit about bleeding, so recognition and treatment of bleeding, both internal and external. Chest trauma and management of injuries to the chest, including blunt and penetrating trauma. Facial trauma, and this is going to cover addressing airway and other critical issues in facial injuries. And then head and neck trauma, and that's going to be managing injuries to, of course, the head and neck. Multi-system trauma, and we're going to cover some complex cases on this slide. Orthopedic trauma, and we're going to assess and manage injuries with pulses, without pulses. We'll talk about that. Soft tissue trauma, and those are going to be injuries to the skin and other soft tissues. And then spinal trauma, and identifying and, of course, treating those. So each category is going to give some scenarios, some questions, some explanations, and step-by-step guides. So, okay, so let's get started. Okay, so what do we need to know about the abdomen when it comes to trauma? Now, make sure that you understand the different quadrants. And so a lot of times we'll tell the students, if you draw this box right here and you relate it to your patient, you could do G, L, A, makes it easier, A, bear with me, sorry, I'm not very good. So glass, it'll spell out glass. Now you have, of course, the gallbladder, liver, the lower right is going to be the appendix, and then the upper left quadrant is going to be the stomach and spleen. Now this is going to be really important in this test and in real life because you're going to want to know the underlying organs for the injuries. So the upper right quadrant, remember we said it houses the liver. It's one of the most frequently injured organs in any type of abdominal trauma. And so, of course, if you have a patient who is stabbed in that upper right quadrant, be careful because it could be the liver. It's very vascular. So remember that when it comes to abdominal trauma. Now, also, when you're treating a patient with abdominal visceration, you want to make sure that you know the steps to that. So do not reinsert the organs, of course. And evisceration is when the organs are protruding outside of the skin. And so I always say when an organ is outside of the body, and it should be inside, always cover with a moist dressing. So that's when you use the moist dressings and not the dry dressing. So use a moist dressing, and then of course you're going to secure it with an occlusive dressing. Now this occlusive dressing is just going to be non-porous, and that's why it's an occlusive dressing. It's going to be taped on all four sides, unlike the chest injury or the chest traumas where we do the occlusive taped on three sides. And then of course you're going to monitor for shock and transport urgently. So next we're going to move into some assessment techniques. Now, let's start with blood thinners. So, blood thinners can significantly increase the risk of severe bleeding and complicate trauma care in elderly patients. So with elderly patients, medications that you should be most concerned about are the blood thinners. That's a very simple answer. When it comes to contact lenses, now they trap in chemicals, and those chemicals against the eye can cause more damage. And so you want to remove them prior to irrigating. This is going to help to prevent further injury. Okay, so remove the contact lenses. A patient with a chemical burn on the eye who's wearing contact lenses, you should remove them and immediately and irrigate with saline. Okay. Now, next assessment technique, removing helmets. And so the helmet can cause further spinal cord injury if it's not done correctly, so removing it. So only remove it if it's essential for airway management. So should we remove the helmet or not? Let's give a scenario. So a patient had an accident on a moped. She's laying on the ground, she's breathing well, and she's still wearing her helmet. Now, should we remove it or no? So what I would say is remove the helmet if the airway management is required. Otherwise, leave the helmet in place while stabilizing the neck. Okay? So next, very important techniques that we need to do is, of course, opening the airways. When it comes to trauma specific, make sure that you remember you're using the jaw thrust maneuver. Patients without suspected injury, spinal injuries, you could do the head tilt chin lift, okay? Don't forget that the OPA, it keeps that airway open in unconscious patients without a gag reflex. Okay, so now let's move into some chest discussion, chest traumas. And when you have severe, like a serious chest injury, flailed chest, for example, which can severely impair breathing. So you need to immediate interventions is required. And what you want to focus on, of course, is the breathing. So you need to ensure that the airway is open, administer high flow O2, and prepare to transport. Okay, so let's talk about somebody who sustained a blunt trauma to the chest, pale, cool, diaphoretic, responsive only to verbal, and if they have a high respiratory rate and shallow breathing with a paradoxical movement, meaning that it's a large portion of the ribs are moving in while the rest of the chest is expanding. So that's paradoxical movement. That is a serious chest injury, and that's most likely a flailed chest. Okay. So let's talk about sucking chest wound. Sucking chest wound, it's bubbling. You could see it by bubbling and diminished lung sounds on one side. Of course, an occlusive dressing is needed to prevent the air from entering the chest cavity and causing a pneumo. So you want to apply an occlusive dressing if you have a patient who's in distress after being stabbed in the chest and you're seeing bubbling from the chest wall. So lung sounds, if they're diminished on that same side, you know that you have a sucking chest wound. So apply occlusive dressing, taped on 3 sides, monitor for signs of detention pneumo, and of course that's going to be tracheal deviation, and then transport urgently. Okay, so subcutaneous emphysema, that's another one that they could throw at you. And basically it happens when trauma to the chest or neck causes a pneumo. And so what you have is you have presence of air in the subcutaneous tissue. And it causes swelling and a crackling sensation when you palpate it. So that's subcutaneous emphysema. Now let's move into commotio cordis. And this one has been a big topic of discussion within the last year or so after the football player got hit in the chest. But basically, it's a sudden cardiac arrest, and it's caused by a blunt impact to the chest, to the center of the chest. And what happens is the patient will go pulseless, unresponsive, of course, suddenly collapse. Now, what is needed, the treatment for commotio cordis is going to be immediate CPR and, of course, defibrillation. Defibrillation is the most important. Okay, so now let's move into facial trauma. So what are we concerned with facial trauma? And of course, that's airway management. 100% airway management should be the top thing that you're focused on. Now, so let's take some scenarios. We have a person driving a motorcycle, hits a parked car at a high rate of speed, not wearing a helmet, and copious amounts of blood around his face and gurgling with a respiratory rate of 4 per minute. Now, anytime you see gurgling on any of these Fisdap tests, you know the first priority is clearing the airway, okay? So airway obstruction is the first primary concern with facial trauma and, of course, with bleeding. So clear the airway. Focus is going to be airway management, and you want to use the suction to remove blood and administer high flow O2. Of course, your respiratory rate of 4 per minute, you're going to be bag valve masking. Okay, and burns to the face. Now, when it comes to facial trauma, burns to the face is going to be another major thing that could create a respiratory injury, any type you have any burns to the face. So it can compromise the airway due to swelling. So immediate treatment focuses on managing and maintaining that airway patency and preventing respiratory complications. So if you have a patient who has burns to the eyes, nose, mouth from any type of steam burns or say a radiator injury, make sure that you focus on ensuring the airway. You could provide humidified oxygen if you're allowed to, or if the test questions includes that. Okay, now after facial trauma, where we're ensuring the airway, we're going to go into head and neck trauma. And I want to start by saying that any person who is unconscious following trauma, you should suspect of having some type of head or neck injury until it's proven otherwise. So if you have a patient who is in the water, who's water skiing, or who just dove into the pool and is now unconscious, you better suspect head or neck injury and make sure that you secure that C-spine. Okay, so a basilar skull fracture. Basilar skull fractures are very classic signs of that are going to be raccoon eyes, and so you have bruising around the eyes basically or behind the ears, and those are battle signs. Now this is those are classic signs of basilar skull fractures, which can have, of course, serious complications, including a brain injury. And so if they ask you something about having bruising around the eyes or periorbital ecchymosis, so peri is around, ecchymosis is bruising around the eyes, of course. Periorbital, so orbit the eyes, and suspect a basilar skull fracture. Okay, so some severe brain injury discussions. If you have a patient who has agonal respirations and a gunshot wound, and there's skull leaking brain matter, there's no radial pulse, the presence of a severe brain injury and no pulse suggests a very poor prognosis. So I would focus on the immediate life-threatening injuries and consider basically it's futile to resuscitate. And so if there's no signs of life, consider termination of resuscitation is basically what your book says. Now, moving into Cushing's reflex. So Cushing's reflex is a sign of an increased intracranial pressure. Now, basically what happens is you have increased pressure inside that closed container. You have one tiny opening where your brainstem is, and it's pushing down on it. So because of that increase in intracranial pressure, you're going to have the irregular respirations. You're also going to have hypertension, and you're going to have bradycardia. And so that's basically Cushing's reflex, an explanation. It's the cause is a traumatic brain injury because of increased intracranial hemorrhaging. Okay. Okay, so let's go to some multi-system trauma. Now, I included two things on this slide. It's not necessarily multi-system trauma. However, I placed it on here for specific reasons. Now, I want to talk about maybe somebody who has an impaled object in their eye, in their mouth. Remember that you're only going to remove an object if it's interfering with the airway. So if you have a pencil stuck in the cheek, make sure that you assess to see if it's blocking the airway or occluding the airway. If you have any type of flap of skin that is in the airway, you need to remove that because basically it's going to cause a complete lack of airway control. So, but when it comes to an impaled object, let's say a stick in the eye, removing that object can cause further damage. So you want to stabilize the object to prevent movement and make sure that you protect, basically covering both eyes, and that's going to minimize eye movement in the injured eye. So do not remove the object and stabilize the object, cover both eyes to prevent it, and then of course transport urgently. Next, we're going to talk about amputated extremity. So I included amputated extremity on this slide as well. And it's because there's going to be multiple questions pertaining to how to manage the amputated extremity. And it's just the amputation itself. Okay, so basically your book is specific about how to manage this. Of course, you want to control the bleeding with direct pressure or tourniquet if it's non-controlled, and then wrap the amputated part in sterile dressing and place it in a plastic bag and keep it cool. Now, transport urgently the patient and the amputated part. So do not place it directly on ice. You have to wrap it, you have to, and keep it cool. And once again, per your book, don't place it directly on ice because it could cause frostbite. Okay, so let's move right along, and we're going to start talking about orthopedic injuries next and splinting. And when it comes to basically the splinting aspect, it's going to depend on pulses. And so let's talk a little bit about if you have a patient who's holding his shin and there's deformity, but you have a pedal pulse present, now that means that circulation, of course, is intact, and you could splint the injury to help immobilize and reduce pain. So monitor for changes in the distal pulse and transport to the medical facility, of course. Now, when it comes to a patient who's fallen, there's a deformed leg, and the distal extremity is pulseless, and the skin is cool and cyanotic, that means, of course, that there is a compromised circulation to that extremity, and you need to try and gently realign it in an attempt to restore blood flow and prevent tissue death. So one attempt to realign the leg to regain the pulse, and then of course splint and transport urgently. All right, now when it comes to something being impaled in the leg and you have an obvious fracture but there's no pulse, now if you remove the metal, it can cause further damage and severe bleeding. So what this question wants you to do is stabilize the metal and the limb to prevent movement, of course. Do not remove the metal, stabilize it, and transport urgently. Okay, so now we're going to go to some soft tissue discussion. Now, basically, when you talk about soft tissue and you talk about any laceration from rust or a rusted chain link fence, just make sure that your concern with this would be an infection and, of course, tetanus. So make sure that they are up to date on their tetanus shots. And then a little bit about ecchymosis. This is from your Fisdap study guide, that form that Fisdap hands out. And ecchymosis, of course, is discoloration of the skin, and it results from bleeding underneath, and it's typically caused by bruising. And so it could, signs and symptoms are skin discoloration and tenderness. All right, simple slide, and we can move right into spinal cord. Okay, so when it comes to spinal cord, I put a kind of a scenario on the slide because I wanted you guys to see that if you have somebody who's shot in the back, of course, you need to consider a spinal injury. Now, of course, if he's cool and clammy and he has just specific arm weakness, this 100% could be a spinal cord injury. So it's going to require immediate immobilization and transport urgently. So, and of course, so your suspected injury is a spinal cord. Okay, so I wanted to talk about a sign of decompensated shock. Now, remember, this is not compensated shock we're talking about. Their body is not keeping up. Their heart rate's not elevating. They've already kind of turned that corner, and now they're in decompensated shock. Now, decompensated shock is a critical stage where the body can no longer maintain the perfusion to the vital organs. So we need to recognize it early. And so a sign of decompensated shock, an early sign, of course, is going to be hypotension, and that's going to be a drop in the blood pressure. Okay, so let's talk a little bit about some key takeaways that we just talked about. Now, when it comes to abdominal trauma, you need to recognize and manage injuries to those internal organs. Remember, when we're talking about the different quadrants, that upper right quadrant is going to be the liver, gallbladder. The upper left quadrant is going to be the stomach, spleen. So a lot of spleen injuries with seatbelts. All right, so assessment techniques, just make sure you're thinking about the medications and proper assessment. Of course, with particularly with elderly patients, taking those blood thinners. When it comes to bleeding, management of internal and external bleeding, including the use of occlusive dressings. Chest traumas, of course, flailed chest, gunshot wounds, understand how you address and treat those. Facial traumas, you want to prioritize airway management in cases with significant facial injuries. Head and neck trauma, you need to be able to identify signs of basilar skull fractures and manage head injuries. Recognize increase in cranial pressure. And multi-system trauma, those are going to be complex cases, and it could involve multiple injuries. So emphasize stabilization and fast transport. Orthopedic trauma is going to be splinting if there is a pulse, and realigning one time, gentle traction if it is pulseless. And then soft tissue trauma, you're going to focus on managing injuries to soft tissues and recognizing the need for that. And then spinal trauma, recognizing and immobilizing spinal injuries to prevent further damage. Now, stay vigilant and systematic in trauma assessments, and always refer back to your NREMT trauma assessment form. Prioritize life-threatening conditions first, of course, and use appropriate techniques for managing those various types of trauma. And if you have any further questions or want any additional training, please do not hesitate to reach out in the comment section. And thank you, and stay safe.